All right, guys, the last of the material for concussion, right? And then we've covered all the material that we're going to cover at least for concussion, right? All that's left is just an exam, comps and practical, right? So here we go. Okay, guys. So kind of putting the icing on the cake, okay, for concussion, right? We've been talking a lot about identifying concussion, okay, diagnosis. We talked about management too, but there's a really important component of concussion that I would be remiss not to go over with you guys. I know this is a techniques class, so really, excuse me, we're focused on diagnosis and management. However, the medical legal aspect of concussion, an appropriate return to play, right? Appropriate return to learn and risk management strategies are part and parcel of what is going to protect you as an athletic trainer, what's going to protect your patients, right? And what will hopefully keep you out of a courtroom, right, as a clinician. So I know we kind of depart from the diagnostic aspect a little bit, but this information is important nonetheless. Okay, as we talked about, okay, the Berlin Consensus Statement, the international consensus statement from 2016 gave us, 10 R's, right, to essentially consider as we not only obviously identify concussions, but as we manage them as well, right? So clearly, one thing that we have learned, right, is there's not necessarily a consensus as to where active treatment strategies are supposed to fall, right, within this spectrum of management. I do think that it is clinically reasonable to implement these once a patient has started to show improvements in symptoms, right? But the thing about it is you have to be really, really observant, and you have to know when to refer, right? You have to know when to make that referral. Obviously, it's going to be highly important that any patient with a concussion is obviously referred to a physician for care as well. That's something that we always need to do. That's not saying that as athletic trainers we don't know how to manage concussion, but once again, we are beholden as athletic trainers to refer because there's always that 1% chance of it being something other than a concussion, and that's something that we don't ever want to miss. God forbid a subdural bleed, so on and so forth. But here's the deal, right? Comprehensive management of concussions, not just only about, right, active treatment, return to play, right? But as an athletic trainer and as a primary care provider, your job is to coordinate care for your patient, both within the realm of athletic participation and outside of it. Because what you're going to find out very quickly in real life and in practice is that, quite frankly, in many, many times, you were the only resource at your university, at the high school that you're employed at, right? Maybe even as an outreach athletic trainer, so on and so forth. Or maybe you're full-time at high school, right? And or maybe you work in performing arts, right? Wherever you work, you'll find that many times athletic trainers are often the only resource. So it's our job to essentially help people coordinate care as they attempt to negotiate life while recovering from a concussion, okay? So it's really important to have policies in place that guide appropriate referral, right? So concussion management plan, right? And also touching on areas like return to learn, which we'll discuss, right? So really asking the question, in what manner and when is it safe for someone with a concussion to return to the classroom, okay? When can they handle academic, basically cognitive demand on the brain, right? Obviously return to play or return to work, depending on the situation, right? And then risk management and education, right? So all of these things are vitally important in formulation of any comprehensive concussion management plan and or concussion policy, right? So return to learn. What is return to learn? So return to learn is really important. And I think it goes without saying at this point, I think we all know that the brain responds to both physical and cognitive demands. Either a physical or a cognitive demand will increase the energy requirement by the brain, increase glucose uptake by the brain, right? And as we remember, right, from talking about this injury, one of the first problems, right, the secondary injury, okay, after the axonal shearing from the primary injury of concussion is changes in metabolic function and an increase in metabolic demand uh, with a mismatch of availability in glucose, right? So cognitive activity also requires the metabolic activity to be able to carry it out. So the role of a return to learn policy or strategy is to manage that cognitive load, right, on the patient by managing and or providing assistance for their time in the classroom, right? So obviously as an athletic trainer, you can't be there with them, but you can coordinate with professors, with teachers and administrators to utilize tools at your disposal, right? And it's different for everybody, different for every practice setting and an athletic trainer, depending on where you work, right? But ultimately, right, you're going to have to utilize the resources that you have to potentially submit requests for temporary academic accommodations, right? Maybe extensions on tests, okay? Maybe having the patient take a test in another room, in a private testing room, and or, submitting requests, to the Office of Students with Disabilities, potentially counselors if you are working in a secondary school, right, to develop your own return to learn program. Right, so this will be very different and it's institution specific. Okay, so obviously because these return to learn policies are institution specific, that means that no two will be the same ever, right? You have to find something that addresses these components, but that works for you, utilizing what you have available in your practice setting, right? The other thing that's also really important too, and this is one of the coolest things ever about athletic training, is that because we work, right, generally and especially actually in the traditional practice settings outside of a fee-for-service model, right, people don't have to pay to see us, right? People would say that that's a disadvantage, and there are definitely arguments to that. But let's look at it this way for 1 second. What about someone who otherwise, potentially someone that is maybe an ethnic minority, or maybe they are someone that comes from a lower socioeconomic status, from any ethnic group, right? Who otherwise, without the presence of an athletic trainer at their school, right, would never have access to medical care in the event of a concussion, right? And because you have put a program in place for them, right, that doesn't depend on their ability to pay for care, right? What you have done is you've erased the health disparity. It's crazy cool, right? You have completely and totally erased the health disparity because of a program that you've put in place, right? So what I have here in these next couple slides is an example of a return to learn policy that I wrote at my last institution. And like I said, this is an example. This is not anything that's hard and fast. This is just what worked for us, right? So obviously, we attempted to target faculty members here, right? And you're going to notice in looking at this that we use two different terms. So in the state of Texas, where I used to practice in the college university setting, we couldn't use the term academic accommodations right off the bat because that implied special, not necessarily special, but required accommodations under the law, right? So we couldn't use the term academic accommodations right off the bat to describe how we were going to assist someone who was returning to the classroom after concussion. So ultimately, right, we came up with different levels of academic support, so to speak, and that could be a term you use, academic support, right? So obviously, when a student sustained a concussion at my previous institution, the athletic trainer or physician implemented that process of academic accommodations or academic assistance immediately, right? And so with the way we set it up, we described that academic assistance or, pretty much as something that was informal and developed, and essentially involved direct communication between the patient and the faculty, right? So we had our own process for setting that up. We had an electronic alert system that we would enter an alert into that would alert the faculty, right? Excuse me. And there were situations in which, with the patient's permission, of course, we would reach out to the faculty member directly via email due to a test, because sometimes it took 24 to 48 hours for these alerts to be processed, right? And so we had obviously our own kind of protocol here. But the one thing that's really important is that we put the patient first, right? And kind of gave them kind of that level of supremacy, right? So ultimately, we had the leeway at my previous school, excuse me, to essentially excuse and or remove a student from class in the event that we were of the opinion medically that it would be counterproductive for their recovery, right? And so once that concussion was resolved, the alert that was put into the electronic system that we utilized was then lifted. Okay. Okay. So obviously the other thing that we tried to do is we also, right, used within our return to learn policy specific references to other policies and documentation that we utilize within this program to essentially cement the authority of the athletic trainer or physician to withhold a student from class. That way a faculty member could not come to us and say, well, I don't know, you should be able to withhold the class. Well, guess what? Myself and my supervising physician are the healthcare providers that are supervising this patient's care. We just withheld them from class. There's nothing you can do about it, right? So in this case, if a student experienced a protracted recovery, right, which fell outside of the 14-day time frame, we essentially escalated their academic assistance to true academic accommodations, right? And so ultimately, true use of a testing room, and at that level, in the state of Texas, there had to be a formal application for temporary disability on file with the Office for Students with Disabilities. So, and obviously, we also kind of gave the room to cover, like, in that 1% chance or less than 1% chance that the patient had to bleed, right? We also cover ourselves with this policy that way as well, right? So this was really, really important, right? And this section down here, I thought was really useful, because when you have people, right, who are otherwise untrained, right, when it comes to concussion, but are interfacing with the patient, they have to have some sort of guideline for knowing how to adjust their class activities. So we kind of gave them some guiding questions or maybe conversation aids, right, to kind of help students out that had concussions, right? Just ask them, how you feeling? You feeling okay? Is today a bad day? Are you feeling, pretty symptomatic? If that's the case, here's what we'll do. We print out the notes. Why don't you just go get some rest, right? So on and so forth, right? So just for, kind of user-friendly purposes, if you're engaging teachers or faculty members, maybe some things like this might be useful for you, right? Okay, and this is the finished product of what we put together for the faculty, and that was handed out to them in print and online, right? Okay, what about return to play? So it's really important to note that generally speaking, return to learn occurs before return to play, right? So when we think about symptom resolution, that's one piece of the puzzle, but it would be medically irresponsible for me to return a patient to play, right, with continued cognitive deficit or inability to function in the classroom without symptoms. Because if a cognitive load in the classroom exacerbates symptoms, they are not recovered. They're not, right? And they're not ready to return to play. So they've got to be symptom-free in the classroom, right? And symptom-free in everyday life, right? Before we can start graded return to activity. So once they've been essentially symptom-free for 24 hours or more, right, we can begin a graduated return to play program. Now, there is definitely debate about the clinical utility of neurocognitive testing. but the people that wrote the guidelines are experts for a reason, right? And so here's the thing, right? While it's true that there are psychometric concerns, right, with neurocognitive testing, and issues with its utility as far as making return to play decisions, remember that's only one piece of the puzzle. And the biggest thing that we see with neurocognitive testing is that there essentially are practice effects because students, like we talked about, they can learn the test over time because they've had so much exposure to it. However, there are things that we can do to help mitigate that, such as increasing the length of time between essentially versions of the test, like post-injury and then prior to return to play. If we think that someone's going to have essentially a practice effect, then we could potentially space out, right, that final neurocognitive test prior to the full contact phase of their return to play progression, right? It doesn't have to be right away, so you have wiggle room as to when you implement that. So again, like we talked about, even though there can be psychometric problems with return or with neurocognitive testing and a practice effect, these still do demonstrate clinical value, right? And even though a patient may not be fully back to baseline by the time they return to play, at the very least, what we should see is an upward trajectory towards baseline values, right? They should be gradually improving, right? And so there have been situations where I, in the past, and along with my supervising physician, did clear patients for return to play, where, even outside of scores that were back to baseline values. But because we saw a positive trend, we made the decision to let them return, right? The other thing, remember the multimodal approach, symptoms, cognition, balance, right? Balance deficits should also normalize, right? Whether you utilize BESS or SWAY, we need to see normalization of balance values, okay? And or a trend back towards normal baseline, right? As we talked about before too, another thing that we can do is if we really want to make sure, right, that they're actually better, right? That those cognitive improvements and those balance improvements are legit. Okay, we can actually take them through an exertional test on the field, and then retest tandem walking, retest balance, and maybe even make them do dual tasking, right? Excuse me, which is the integration of a physical and cognitive task. So, for example, having them tandem walk to you, heel toe, while counting backwards from 100 to 0 by fives, right? That's dual tasking. Okay, they have to essentially perform a cognitive task, okay, and a balance task, or even doing something like having them stand tandem and or walk tandem while utilizing the Stroop test. Okay, those are all good things. Okay, here's an example, right, of a return to play progression. This is what we used. Okay, still in step with the guidelines that we're still using today, right? So day one, what did we do? Okay, we established the student athlete's max heart rate, and remember, by this point they were asymptomatic. Okay, this is different than determining the subsymptom threshold for daily activities. Okay, different, because at this time they're symptom free, and we take essentially 220 minus their age, determine their max heart rate, right? And we take them through a 20-minute bike ride, right? That's normal. We test tandem walking and coordination. Okay, then we progress to day two. You can see so on and so forth. Okay, then we're bringing in anaerobic activities, right? Push-ups, sit-ups, squat jumps, right? And sprints. So sorry. Okay, obviously, normal balance, normal coordination. Then we have weightlifting, okay, followed by a non-contact practice. All right, so day four, if that goes well, they can then resume full contact. Day five, followed by gameplay. Okay. All right, here's the deal. Okay, let's talk a little bit about risk management. What about Sorry. What about laws? What about when guidelines that we have are backed by state law, particularly in the state of Minnesota, right? So Minnesota actually does have a concussion law, okay? And this concussion law applies to both youth sports, right, and secondary school activities, okay? So obviously here in the state of Minnesota, and you can Google this, right? This is actually the statute number that discusses concussion. Actually, I put in a link here that should work. It'll take you to the page, okay? But obviously defines concussion here. And ultimately, right, the other thing that this also lays out are different rules for both youth and secondary school sports. Now, here's the thing. They actually, in the state of Minnesota, okay, school-sponsored sports, and it says the appropriate sports governing body, including the high school league under Chapter 128C, among other sports governing bodies, excuse me, shall work with public and non-public school coaches, official and youth athletes and their parents or guardians to make information available about the nature and risks of concussions, including the effects of continuing to play after receiving a concussion, right? So obviously the information shall include protocols and content consistent with current medical knowledge from the CDC. Okay, so obviously in Minnesota, and you can look, I would encourage you to look up the statute, click the link in the previous slide, take a look at the statute, take a look at the laws, because if you're practicing in Minnesota, this applies, right? So as an athletic trainer in Minnesota in the secondary school setting, you have to distribute concussion education materials yearly, right? You actually have to retrain your coaches on concussion education, re-educate them once in a 3-year period. And, okay, coaches and officials, particularly per the international consensus guidelines, are required to recognize and remove. Okay, if they see someone that they suspect of having a concussion, they are required by law to remove them from play. And obviously, it says here that an athlete may not return to play until cleared by an appropriate provider. They do not specify who that appropriate provider is within the law. Could be a physician, could be an athletic trainer. In the state of Minnesota, could also be a PT. There are obviously opinions on that. That's a big source of debate. So, all right, risk management. So obviously, guys, another big thing, right, that you guys are going to have to contend with is the culture surrounding concussion, right? So as I'm sure all of you are aware, there is a problem with symptom reporting. People don't report concussions when they happen. Okay, there's nearly 3.8 million concussions that happen per year, and nearly only 50% of them are ever reported. So nearly 50% of these concussions are going unreported and therefore unmanaged, right? So clearly that's a major concern. And a lot of this, you guys, comes down to a lack of education about the risks associated with concussion, and also the potential effects and long-term symptoms that can present themselves after continuing to play with a concussion, right, and not reporting it and not seeking treatment. Sorry. So what is this? Okay, this is essentially an introduction to a framework known as the socio-ecologic framework that seeks to essentially describe and or understand why concussion symptom reporting is such a problem, right? So it takes into account things like the patient's own personal level of education and or their beliefs, right, about concussion. Takes into account interpersonal factors. Perhaps that patient or that student athlete, excuse me, is receiving pressure and or bad information from a parent, from a coach, right, that says, oh, concussions aren't that bad. You just got your bell rung. You don't need to tell anybody that you're hurt. This will go away in the morning. Don't worry, you're going to wake up tomorrow morning and it'll be fine, right? So there are obviously interpersonal factors that go into lack of reporting, excuse me, as well, right? And then obviously environment, team culture, right? So team culture with an emphasis on toughness,
right? Winning and playing at all costs, no matter what, right? Can impact the patient's ability to make decisions. And like I said, coaches and the interpersonal relationships that student athletes have to deal with have an impact on their team, right? So it's extremely important to educate coaches, even per the law in the state of Minnesota. It's extremely important to educate coaches and stakeholders, right, to attempt to kind of create a change in that shift, right, and create a culture to essentially, obviously, promote reporting of symptoms, right, and ultimately also creation of policies and laws, like we've seen in the state of Minnesota and many other places around the country, where laws have been put in place to not only protect, patients and student athletes, but also to mandate, excuse me, also to mandate education, right, for coaches, for parents, and for student athletes. So obviously, this is a very kind of brief treatment of a lot of these kind of topics. But guys, this is the 30,000-foot view, right? All the way from diagnosis and management through even return to play and medical legal issues, right? This obviously, all this content's been meant to serve as an introduction. In your career as an athletic trainer, you will continue to obviously confront these things on the daily with your patients, and you will actually also continue to make more of a deep dive into this problem and learn about this more deeply, right? So, guys, I really appreciate your patience, and thanks for sticking with me as we learn about concussion. Okay, thanks.